Hello, everyone. Hope you can hear me. My name is Vishnou, one of the BitePACES faculty. Um, Hopefully, you can see my slides. So today is going to be a clinical consultation session, and the main aim is to try and get everyone more comfortable with what is perhaps one of the hardest stations in PACES. And I'll demonstrate sort of my tips, how I would approach certain stations, and we'll have some real life practice. We've already got some volunteers, so thank you so much for those who volunteered. Um, so before I start, I just wanted to just say that about PACES, obviously, um, I, I'm one of the faculty members. I teach on the course, and it's during PACES, when I was in your stages, I went to quite a few courses, and I actually did bike paces as well. And I think um, obviously each course has its own sort of strengths. But the thing about bike paces was really brilliant was you go around in pairs, so you've got a really good ratio compared to some other courses where you may be a group of five or six going to see one patient. You're always usually in pairs going around sort of, and you're being taught on how to pick up on clinical signs, which is the key thing in PACES. Then, of course, there's the consultations and the communication skills as well. We've had excellent feedback for the last few courses, and I'll post a link for the next diet for the waiting list. So please do keep tuned for that and also for future webinars. Um, if there's any questions at any point during this talk, please do just um, yeah um, just either raise your hand or put it in the chat and I'll try and see it. I've just made sure that everyone can talk as well. So if you can't, let me know. Okay, so let's start with the clinical consultation. So the aim of this session is to introduce what is the clinical consultation station, what is expected of a PACES candidate, and I'm going to try and give you an approach to these stations to enable the highest scores possible. And we're going to cover common presentations. So every single case I've selected today is a real life station. Okay, so it has appeared in the last 2 to 3 years in PACES um, as a station. Um, you may have seen some previous talks, webinars. I feel like I always want to just remind people that this is the PACES carousel. Hopefully one day they'll move the 23, but just to emphasize that the fact that the PACES format has changed. So we're talking about the station 2 and 5 in particular. Um, and again, if you use older resources, you may notice that the stations seem to be much smaller, and that's because each of those stations were 10 minutes and is usually sort of two complex patients as one station, and you did have 10 minutes each to do history, exam, talk to the patient, and a quick Viva. Now, before the station, you get a brief referral letter. I'll show you some examples, some investigations, and you've got 15 minutes to do a history exam and sort of respond to the patient and come up with an agreed management plan. So I've sort of come up with my own suggested timings, and these aren't fixed because sometimes you do need a bit more time in the history, and sometimes you don't. There isn't much to examine. Okay, so it is fluid, but I think at the 4 minute mark, you need to just think about, okay, do I need to move on to examination? Okay. And then when you're on to examination, remember you can always ask questions. That's the difference between the examination stations. You can go back and forth between the history and exam, um, just quite like normal practice. Okay. But my advice would be to take enough of a history that's focused to allow you to definitely decide on which examinations you want to do and also think about why you want to do them. Then I think you need to have a bit of a buffer time to explain your management plan to the patient. The patient will have specific questions that they will ask you. And I realize I've used ICE, and maybe not everyone on the call knows what ICE is, but ICE stands for ideas, concerns, and expectations. So these are things that you have to address. So ideas would be, what have they heard about this condition before? Concerns, how would they affect them and what they're expecting to get out of the consultation. Is it a medication? Is it treatment? So those sort of things. After the 5 minutes, you have um, 5 minutes viva. Sorry, after the 15 minutes, you have a 5-minute viva with the examiner. Here's the here's what skills are being assessed throughout PACES. Okay, so this is not just the clinical consultations, this is throughout PACES. Um, and this is why this stations are important, station 2 and 5, because this is the only two stations in PACES where you're examined on all 7 skills. Okay, so it's a bit like a driving test. You get examined, and if you have too many minor faults, you could fail. And obviously, a serious fault, inverted commas, you could also fail overall. Okay, people do not fail PACES outright. They fail PACES because of one of these categories, not getting enough marks, usually. Okay, so here's an example. So this is from the PACES website, MRCP website. So this is what the sort of format is. So on the left-hand side, you can see that they've given you patient details, they've explained what your role is, and they've done a referral letter. Okay, so you have a few minutes before you go into the station to prepare some notes. Okay, so your task bit is always the same, and it'll tell you how much time you have. The clinical referral is this patient's had a blackout, but now seems fully recovered. Routine blood tests, which are below, are normal. Sorry, routine bloods are normal, and the observations are below. Please advise regarding his diagnosis and management. So not a lot, but there is some information there, isn't there? So he's got completely normal observations. If we quickly look, his respiratory rate is surprising, not 18, but it's it's normal. So here's what I would do if I were you. So the first thing you have to remember is in these clinical consultations, and in fact, the all of PACES, they're trying to work out, could you be a medical registrar? Okay. So you need to think about the logistics. It's not just about, can I get the diagnosis here? It's about the logistics. It's about where does this patient need to be in the hospital? Who do I refer to? Who's going to look after this patient? So those sort of things are quite important. So remember, you're an MAU, okay? So that means the patient's presumably already an inpatient or already been referred onto the medical take. Okay, so that's already happened. We'll come up with a differential diagnosis before you go into the station. So okay, so write down, you know, some conditions have a small list, some of them have a huge list. This one obviously has a pretty long list, doesn't it? Blackout. Think about which systems you're going to examine. Okay, this is really important because one pitfall in PACES is you start examining things that you don't really know why you're examining just because you feel like you have to fill time. So you don't have to do that. If you're comfortable with what you've examined and it makes sense, that's fine. You can then move on to explaining things, and then you can always come back and examine other things. Um, I think it's very key to leave time to explain to the patient because those are specific skills that are being assessed in the clinical consultation. And please remember, always, always, always cover safety points. So blackout, the obvious one is DVLA rules for driving. So here's the mark scheme for this station. Okay, so I've just caught a bit of it out, so you can see what they're looking for. Okay, and I hope this is useful. So you can see like the clinical communication skills. So the history obviously has to be adequate. So you can't just take a history for one diagnosis. You have to think about all the other diagnoses of seizures, for example, AF and all of those things. Physical exam, they've asked for a focused cardiovascular and neurological examination. So they're not expecting you to do a full Clarkin examination. Okay, so that's not what the clinical consultation is meant to be doing. This is going to be a normal exam. Okay, so this patients come in with a vasovagal. Is the diagnosis here, or potentially arrhythmia, which will both be completely normal exams, won't it? Um, Clinical judgment, so coming up with normal, a good reasonable differential diagnosis list, and therefore coming up with a reasonable investigations list, excluding some of the more concerning things and also the more the simple things in order. Um, can you see there's a specific point about implications for driving? So if you do not address driving, you're going to start losing marks on clinical judgment. And so this in this scenario, which we didn't know about, but obviously the patient would have told you if you asked, they have AF, so you need to think about anticoagulation as well. Um, Manage your patient concerns and welfare. It should be pretty self-explanatory. I'm just going to pause here and just see if anyone had any specific questions at all. Um, and I'm just going to make sure that more people are allowed to talk. I'm just checking on the thing. Okay, so if anyone has any questions about the MART scheme or how PACES works in terms of the clinical consultation, please do let me know. I'm going to just allow for a few more. So I'm just making sure that everyone's allowed to talk. So just in case that's something, sounds like we're all happy with that. Okay, well, since we're all happy, I'm going to move on. So this session, because at the start I did say that we're going to have three cases, and I actually want um, some candidates. So I three people very kindly offered earlier. Um, so I'm going to choose the first person randomly, if that's okay. I'm really sorry if I'm not saying this name right. Ewan. Don't know if it's L or I. Liwen or Ewan.
Hi, yeah, can you hear me okay?
Yeah, I can hear you. Perfect.
Yeah, okay. Love it.
Sorry if I got your name
No,
wrong.
it's all right. My name's a bit of a nightmare. Don't worry about it.
Uh, Yeah. Okay. So let me just explain to everyone how this session will work. So what we're going to do is we're going to do 6 minutes. So remember, as I've explained, you've got 20 minutes as a station where you do 15 minutes of history exam, talking back to the patient. But here, because you can't examine me, obviously, we'll do 6 minutes for history. You can take up to 7 minutes. Okay. I will just probably show you a slide with some examination findings if there are any. Okay. And
Yeah,
then there's 3 minutes talking to the patient. Okay. So basically in total, there's be a 10-minute station. Yeah.
yeah.
Perfect. Any questions at all?
No, that's fine.
Amazing. Okay. So we've got three cases today. So you're first up because of the random luck I've chosen. Yep, practice station one. So I'm going to let you read that for a minute or two. And I will let if anyone else has any questions in the meantime, I'm happy to take them. Uh, Let me know when you're ready.
Sure. Okay. Um, yeah, whenever you're ready.
I'm ready. All right, your time starts now.
Okay. Hello, is it Mrs. Grieve?
Yep, it is.
Hello, Mrs. Grieve. Pleasure to meet you. My name's Dr. Jan Davis. I'm one of the doctors in the on the medical team today. I'm sorry to see you're unwell. How can I help?
Uh, Look, I've just got lots of temperatures at home, and I've not been feeling great.
Okay.
So yeah, I don't know what's going on, to be honest.
Yeah, of course. Tell me a bit more.
Well, it's it's been going on for a couple of. I've not been feeling great for a couple of weeks, to be honest with you. But last week I've had temperatures going up to because I bought a thermometer during COVID, so I've got the temperatures and it's going sort of 38, above 38 all the time. And it just
Okay.
knocks me out for the entire day. I just don't, yeah, I just feel so tired all the time.
Yeah, absolutely. Okay. Have you noticed anything else going along with it?
Um, not really sure what else. I mean, I just feel just generally rotten.
Okay. All right. Can I just clarify with you? I see on the letter that you've got a history of previous cardiac surgery. Can you just tell me a bit more about that?
Oh yeah, yeah. So I think so they found I had a murmur or something like that. I think it was quite a few years ago actually.
Okay.
And then my heart wasn't in a good place because I I guess I just got breathless and I had chest pain.
Okay.
So about a year ago, well actually it was probably about 8 months ago, they 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 replaced the valve.
Okay. All right. Do you know which valve they replaced?
I'm not too sure.
That's okay. All right. Okay. So prior to this last couple of weeks, have you been feeling otherwise well?
Yeah, I've been all right. I mean, now you mention it, before I had the valve change, like I felt like a new person, to be honest. After that, they did that surgery. It was a bit of recovery after, but then I was fine for,
Okay.
sort of 6 months, and then yeah, then this happened. Yeah.
Have you been coughing?
No, I've not been coughing. No, because I do sometimes get like I've got COPD
Sure.
as well. And I'm
Sure.
on inhalers, and I do sometimes get like an infection, but I've not had one since
Okay.
December.
Okay. And is your breathing, is that worse than normal at the moment, or is it about the same?
It's about the same. Yeah.
Okay. All right. Any problems with bright lights or stiffness in your neck?
No, no, not at all.
Do you have a skin rash?
No, I don't have a rash.
No. Okay. Any painful joints?
I guess my joints hurt. Yeah,
Sorry,
I guess my joints hurt. Yeah, they do. But
which
I mean,
ones?
I don't know if it's just old age or not. I don't know.
Okay. How long have they been hurting for?
Um, I don't know, just a couple of days. I don't think it's a huge thing. I think it's on and off. I have the odd knee pain and
Sure.
things like that.
Sure. Any pain passing urine?
No,
Any pain in your back?
no, I haven't got any pain in my back. No.
Okay. All right. Um, and any vomiting or loose stools?
No vomiting, no, no loose stools, no.
Tummy pain?
No, I haven't got any pain in my tummy.
Okay. All right. Any recent travel?
No, I've not left anywhere. No,
Anyone unwell at home?
no.
No. Okay. And aside from the COPD and the cardiac surgery, any other medical problems?
I've got high blood pressure and high cholesterol, but nothing
Okay.
else.
Do you take which medications do you take?
I take a statin, and with my blood pressure, I take I think it's amlodipine or something like that.
Okay. Are you on blood thinners for the valve?
Don't think so. No, I mean
No.
I'm on
Okay.
aspirin, I think.
Aspirin. Okay. So we need to double check your drugs, don't we? Any allergies?
None that I know of.
Okay. Do you smoke?
No, I don't smoke. I mean, I used to, but I don't
Okay.
not anymore.
Well done for stopping smoking. Uh, do you drink alcohol?
I've cut down. So to be honest, I don't drink. I probably only drink at Christmas and
Okay.
at parties and stuff.
All right. And who's at home with you?
Well, it's my husband. Just my
Yeah,
husband now. Yeah, all the kids have obviously moved out and
they've moved
they've
out.
got
Okay. And are
yeah,
you
they've got
fully,
grandchildren and stuff.
yeah, and I've got on the referral letter that you're independent at home, is that right?
Yeah, I don't need any help. I don't. I don't.
Brilliant.
I'm
Okay.
pretty good. Yeah.
Um, do you drive?
No, I don't drive. No.
Don't drive. Okay. And what do you do for work, or what did you do?
I used to be a secretary when I was working. Yeah,
All right.
I mean that's sort of I don't know 20 years ago.
Okay. Have your symptoms had sort of a big impact on you at home, or?
But yeah, I mean I'm completely flat. Like I said, I'm pretty good normally, and
Yeah.
I've been in bed most of the time. I
Yeah,
just
absolutely. Okay. Okay. I'd like to move on to examining you now, if that's okay. Is
yeah, sure.
that all right?
Yeah, that's all right.
Okay.
Okay.
So I think the main things are going to be looking closely at my timer, looking closely at her nails for signs of infective endocarditis, an examination of her cardiovascular system and listening to her valve, a look at her eyes, throat, lymph nodes in the neck, um, listen to the chest, a press the tummy, and a good look for any vascular rash, and also a press down her back to elicit any spinal tenderness. Check briefly for neck stiffness. Yeah.
Okay, I'm going to try something here. So let's see if this works.
I've just realized what that picture actually is.
All right.
I can't really hear anything.
No, it's a shame. Um, I will send the slides around. Is that it was actually a real patient, but there's someone talking in the background. It's a bit annoying. But it was a good quality recording otherwise. Basically that's a loud second heart sound.
Okay,
Okay. So that's a loud second heart sound, and you can obviously see the other bits of.
sure.
Okay, so sorry, I'm back as a patient. So go. What would
Okay.
you do now?
So is that are there any like specific examination findings?
Apart from what you can see now, everything else is negative.
We've got a midline stenotomy and what look is slightly blurred, but I think some varicose veins. I can't see anything else really clear. Okay, all right. So look, I'm glad you come in to see us today. I think that the main thing that is clear from your initial investigations, you know, you've got a temperature and the markers of inflammation on your blood tests are raised. Um, I the thing that I would be immediately concerned about, given that you've got a valve in your heart, is that we investigate you for possible infection of that and also run some further tests to look for infection anywhere else. So I think we should admit you to hospital with this. I think we should send some further blood tests trying to grow any bugs in your bloodstream, test your urine. I need to look in the backs of your eyes, do an x-ray of your chest. Once we've got all of those initial tests sent off, I will have a talk with our microbiology team, and likely start you on some antibiotics. But given that your blood pressure and your heart rate are okay, I think we've got a little bit of time just to take all of those investigations in the first instance. And then we'll look to get you on the right treatment that's going to get you better. And I'll ask for you to see one of our cardiologists, and also they will likely need an ultrasound of your heart. Does that sort of make sense? Were there any specific concerns that you wanted to raise?
Are you sort of saying that the valve may not be working then? Is that what you're saying?
Um, so I can't remember. Did we talk about having a murmur?
Yeah. Well, a loud second heart sound and a ejection systolic murmur. Sorry.
Okay, ejection systolic. Okay. So at present I can't allowed second heart sound injection systolic. Okay. I can't hear a murmur that would be in keeping with the valve not working, but I think with features suggesting infection, I think we should always be aware of the risk of infection of the valve, and that would be my main concern.
Would I have to stay in hospital then for this?
So I think you should be in hospital for now, just while we do these first investigations. And then hopefully we'll move forwards in the coming days in terms of and we can hopefully rule in or rule out whether you've got any infection with that valve.
Okay. And do you think I may need another surgery then if the valve isn't, infected or something?
I think that's a really fair question. I think we're a little bit early for me to be able to answer that really clearly. Um, and so we need to do some more tests in terms of blood tests and then ultrasound tests to look at your valve. It is a possibility, but at this stage, it's definitely not a certainty that you need it.
Okay. End of station.
All right.
Um, okay, so how do you think that went in terms of your sort of own reflection?
Um, I think okay. I realized I'd written down some of the blood tests, but I hadn't written. I feel like when it came to the answering concerns and communication section right at the end, I slightly like leapt into it a little bit and then like talked for quite a long time. And may have like elucidated her issues a little bit earlier.
Yeah.
Um,
Okay. So just for this one, I was going to break it down a bit more. The future, the next two candidates will have a Viva straight after, but I'm just going to break it down. Like, it's a bit unfortunate that the audio that I recorded a couple of days ago hasn't worked. So that's a shame. But as you can see, it's a slightly tricky station to do over line. Um, okay. So I'm going to go into Viva mode and ask you a couple of questions.
hmm.
Um, so what do you think this is?
So I think the first concern would be about infective endocarditis of a prosthetic aortic valve, which would be in keeping with loud S2. Um, the ejection systolic murmur wouldn't really fit with, usually in the acute phase, you would be more concerned about a regurgitant murmur. Um, but I think there weren't any other clear localizing sources of infection, so I think that needs to be at the top of the differential.
And what would your next steps be?
So admission, 3 sets of blood cultures, complete the septic screen with urine dip fundoscopy, chest x-ray, initially transthoracic and then likely transesophageal echocardiogram. Um, Once we've got the 3 sets of blood cultures sent off, most likely, I think a discussion with microbiology in the first instance, but it's likely to be empirical antibiotics for prosthetic valve endocarditis.
Yeah, anyone else that this patient will be ultimately referred to?
Certainly cardiology and infectious diseases.
Yeah, anyone else?
Essentially the cardiothoracic surgeons.
Okay. And what is the prognosis for someone with prosthetic valve endocarditis?
It's not good if they're not fit for further surgery. It carries a high mortality rate.
And what are the common causes of infective endocarditis in a prosthetic valve?
So in the immediate post-operative surgery period, sort of less than 6 weeks or less than 2 months, staph epidermidis, and then later on you've got recurrence of the normal organisms, so Staphylococcus aureus, um, group A streps, um, and then sort of further causes of infective endocarditis.
Okay, that's the end of the questions.
Yeah.
Let's just review the case. So yeah, so this is your feedback. I'm just going to leave this slide up. So um,
Yeah.
just as a simple thing. So your management, your history is fine. There's no sort of anything else I could say about it. It was good. It was thorough. You kept a wide differential list. I think the cardiac surgery just always makes you sort of start thinking about what else could it be. Um, and as soon as you see that midline stenotomy, I mean, it's going to be you've got to worry about a valve endocarditis, don't you? The only thing is working out which valve it is, and also looking for a regurgitation murmur, so aortic regurg in this case, which is why in a normal clinical consultation, I would argue that there's probably not much use doing things like the whole cardio exam, but here you might as well have done the whole cardio exam because you really are looking for all the signs of infective endocarditis. which may not be apparent straight away. Um, so that's good. I think your self-reflection on the sort of how you approach the sort of questions were, I think was quite fair. I don't think it was I don't think you I didn't feel that you didn't answer the questions that the patient had. So I felt all the questions were answered and it was quite, quite clear and good communication. So the patient obviously knew exactly um what was going to happen. So I think that was all good as well. Management was completely appropriate and right team. The only thing you didn't say was a lot of places, in fact, I think in almost every place now will have a local infective endocarditis MDT to refer to. Um, and I think that'd be something else that you can use. I've just put down just key points that this is basically it, isn't it? That what you're going to tell the patient. She's going to need lots of you're going to take lots of blood cultures, you're going to keep her in, and you're going to start some antibiotics for prosthetic valve endocarditis before you get some further information from your blood cultures. She's going to have a scan of your heart, probably a transthoracic echo in the first instance. Um, and in terms of a question about surgery and replacement valve, well, you're going to say that it's going to have to be discussed in a meeting, and after they get the scan of the heart, you got to have a better idea of what to do. So I think
Sure.
that's how I would have left that. But yeah, so this is something I actually got in my cases, which it's not the usual sort of rare diagnosis. It's something that's relatively common, or more common than you would expect for a PACES clinical consultation. I wonder if anyone has any questions on this case, or you can unmute, you can put it in the chat.
Just a quick question. What kind of reminders or in terms of timing will we get from the examiner? Is it like 2 minutes or 1 minute remaining?
So you get a 2-minute warning, and that's it. Yeah.
Thank
So you
you.
get a two
Thank
minute.
you.
That's it. So basically, you've got to be able to pace the consultation yourself. Okay. So if you're getting a 2-minute warning, and you're still on examination, well, it's a bit tight. Yeah. So that would be a marker for you to finish your exam and start talking to the patient, as an absolute thing, which is why I'm trying to be quite aggressive with the history, as in I'm really curtailing the amount of time, because so yeah, that's the thing. And also in exam, for you to integrate everything does take a bit of time, doesn't it? So yeah, that's why though that's the reason, for my personal reason, for those timings I've mentioned. Any other questions at all? uh there's a hand up.
Hello.
um
Hi, can you hear
Hello.
me all right?
Yeah, I can hear you.
Hi, first of all, thanks for this great session. And well done to the candidate, who I think he really did a brilliant job. So well done for that. Just a quick question. After eliciting the presenting complaint, would it be best to sort of run through a system approach, as in eliciting whether there was a cough or any other infective symptoms, rather than jumping straight on the cardiac surgery, which indeed was, the what the patient had, which actually made the consultation more efficient? Or it doesn't really matter which way we're going into in terms of, the classic presenting complaint, history presenting complaint, then past medical history, etc. Thank you.
Okay, so good question. So basically, the my answer to that is that the reason why they put the cardiac surgery in the referral letter is what I would say. Okay, so I think you've got to address it, um, and because it was addressed early in this consultation, we got a very clear idea of what it could be, right? So the cogs sort of start to, turn in, and you're already thinking, oh gosh, could this be infective endocarditis? But you're right in that the mark scheme will say you have to screen for all the other stuff. So meningitis was screened for, cough was screened for, in terms of COPD, everything was screened for. Whether you did it the other way around, is you're not going to lose any marks for it. It's just I think if you did it this way around, as in the way it was done this time, you've got a bit more time in the background to just work out exactly what you're going to examine and what are you looking for in particular. Does that make sense? So I think address something that's on the referral letter early because it obviously was there for a reason.
No,
Any other
absolutely.
questions?
Absolutely. Thank you so much for that. Cheers.
No other hands up. Okay, let's move on to the next next thing. So let's see who's in why. Manon.
Hi,
Um,
can you hear me?
yeah, you're a bit quiet, Manon.
Can you hear me?
I can hear you now. Yeah. Okay.
Okay.
Um, right. So here's your station. Oh,
Right.
you've got about 30 seconds. Sorry, I'm being a bit stricter with timing now.
Okay.
And just let me know when you're ready, and we'll so similar as the last one, be sort of 6 to 7 minutes for history, 3 minutes to explain to the patient, and then we'll just do a couple of questions with the survivor.
Mm. Right. Okay.
Okay, ready?
Yeah.
Let's go.
Hi, Mr. Timms. My name is Dr. Said, one of the ED doctors. Uh, so you have come to the emergency department because you were having tremors and sweating. Can you tell me a bit more about it?
Yeah, so I've been a bit shaky. I've been just sweating for the last sort of day. I don't really know what's going on. Yeah, I can barely hold anything really.
Right. Okay. So when did this start?
Like I said, just a sort of afternoon yesterday.
Right. Okay. And do you think that this has been progressively worsening?
Right, yeah. Mate, I don't know. I think it's just it's just been there. Yeah, I don't think it's
Right.
I don't feel like it's getting worse though.
Okay. So this has been a constant thing since yesterday.
Yeah, I mean it's been constant. I mean it goes up and down, but it's been constant, and I get a bit more sweaty.
Right. Okay. Right. And did it start suddenly or gradually? How did it start?
Um, I don't know really. I guess it was sort of sudden. I'm not sure. I mean, the sweating was quite sudden,
Right.
but I'm not sure about the tremors or the shaking. I don't really know, to be honest.
Right. Okay. Is there anything which is making this worse, these tremors and sweating? Do you feel that anything that's make it?
I've not been able to sleep, to be honest. I've not been able to
Right.
sleep at all actually last night, and I don't think that's helped.
Right.
Um, but yeah, I mean, it's not. It's just a bit annoying, isn't it? I can't hold anything anymore.
Right. Okay. Um, have you tried any medications that would help with it?
I don't know even what to try.
Right. Okay. Right.
Is there any medications that would be helpful?
Well, let's talk a little bit more about it, and then I'll be in a much better position to tell you about that. So, have you noted any other problems along with these tremors and sweating?
I
Shaky.
just feel on edge, I guess. Just
Right. Any issues like uh, fever? Have you noted any recent fever? Have you felt feverish?
feel hot, but I don't think I've got a temperature. Um, the person said I was a bit warm when they do the temperature outside, just outside,
Right.
in, in the A&E. That nurse.
Right. Okay. Have you noted any recent lumps and bumps in the body?
Don't think so. No,
Right. Have you been recently more pale? Has somebody told you that you look more pale as compared to normal?
no, I don't think so. No,
Have you got any joint pains or back pain?
no,
Right. Okay. Have you noted any recent weight loss?
no. I don't have any weight loss. No,
Have you noted any weather preferences recently? Like you feel better in cold or you feel better in a hot sort of temperature? Anything like that?
not really. No.
Right. Okay. How's your appetite like recently?
I mean, I don't feel that hungry to be honest with you but yeah, I mean, it's not changed.
Right. And you recently haven't had any flu or coughing, anything like that?
No, no, neither.
Mm. Okay. Any itching or rash?
No, no, no itching, no rash.
Right. Okay. Have you said that, so since you were having a lot of sweating as well, so how bad is the sweating? Do you sweat to an extent that it wets your clothes or anything like that?
Last night I did, yeah. I mean, like I said, it's bad. Yeah, I don't really know why.
Right. Okay. Okay. Have you noted any chest pain, shortness of breath, coughing?
No coughing, no shortness of breath, no chest pain.
Right. Any headache or sickness?
I feel a bit nauseous, yeah. Feel a bit nauseated. You say headache?
Yeah.
I guess my head is banging, yeah. I think I do have a headache, yeah.
Okay. And how bad is the headache? In terms of intensity, how would you rate it?
Yeah, it feels like it's intense, yeah.
Right. Okay. Um, so what's the character like of the headache? How would you describe the headache? Is it like,
It's just all there, I guess.
okay, right. But have you vomited?
No, I've not vomited.
Right,
I just feel sick.
right, okay. Um, have you noted any issues with your vision?
Bit blurry at times, but I mean it's normal now. Like no issues now.
Okay, right.
I mean, like I said, I've been waiting for such a long time. But, I came to A&E like 7 hours ago, and I've just, you
Okay,
know, I've sort of been waiting. I don't know what
right.
this really is.
Sorry to hear that. So, right, okay. Uh, any issues with the tummy pain or any loose motions, loose stools?
No, I don't have any of those.
Okay, right. Any issues with your waterworks?
No, no issues.
Okay, right. Do you have any previous medical illnesses?
None that I know of.
Okay, no, okay. Are you on any regular medications?
No, I'm not.
Right. Are you allergic to anything?
I'm not allergic to anything.
Right. Uh, okay. And have you recently traveled anywhere?
I've not traveled anywhere. No,
Okay. Do you have any family history of any illnesses?
no, I don't.
Right. Okay. Work-wise, what do you do?
Oh, I'm a builder.
Okay.
You're at 7 minutes, by the way, but you can carry on.
Okay. Uh, do you smoke, drink?
Uh, I do smoke and I do drink.
Right. How much do you drink?
Um, Not a lot really. I just, maybe 2 or 3 cans of lager,
Right.
and sometimes yeah, a few shots sometimes, but not that's only when I'm with the mates.
Okay. Okay. I would like to quickly examine you as well. I would look for the tremors in the hands, do the hands examination, take the pulse, and then look for the thyroid. Uh, do the thyroid examination, look for any Graves' disease signs in the eyes, and then listen to the heart as well, and do the abdominal exam.
Okay.
Yeah.
So there's no proptosis, eye movements are normal. Um, and these are the key findings that you see on your abdo exam.
Right.
And your heart sounds, patient's tachycardic, by the way, is normal.
Right.
And he's got a bilateral course tremor, as you can see.
Right. Okay. Right. Okay. Right. Okay. Right. Mr. Timmons, is there anything you want to ask me? Is there anything which is
What
concerning?
what's causing this?
So, based on the history and the examination which I did, it seems like we need to run a few tests. It's not very clear from uh, at the moment that what's exactly causing it, but there are a few things which are making sense at the moment. One of those would be a problem with the gland in the neck that is called thyroid. Sometimes its increased functioning can cause such sort of symptoms. The other thing would be that we would like to do a few blood tests to see how your blood sugar levels are. Sometimes there could be uh, decreased levels of blood sugars. It can lead to such sort of symptoms. Um, so I would like to do a few blood tests, and then then I would be in a better position to tell you exactly what's happening. But at the moment, it seems like we need to keep you in the hospital and run a few tests until we know what exactly is happening and what's the reason for that. Would that be okay with you?
Okay, but I mean, it sounds like you don't know exactly what's going on. Can you make me feel better now? Because it's my heart's like I said, I've still got this tremor. I'm still shaking all the time.
Well, definitely I'll arrange for some medication. And what I will do is I will also ask one of my seniors to come and review you, and we'll try and do our best for you.
Okay. Um, I'm going to move on to the Viva.
Okay.
So, what do you think the differential diagnosis is?
So differential diagnosis, I would consider the possibility of hyperthyroidism.
Okay. What features of hyperthyroidism did you notice in this clinical examination?
The patient is tachycardic. Um, the patient has tremors. Patient has been sweaty, so a thyroid storm sort of a thing that might be a possibility.
Would the length of the history point to this?
Uh, that I would also consider a possibility of um hypoglycemia probably causing this, which could be secondary to some underlying um tumor sort of a thing going on, insulinoma sort of thing.
How would an insulinoma typically present?
So hypoglycemic attacks, repeated hypoglycemic attacks.
Yeah. But would it be in such a short period of time?
No, it would not be. So yeah, and
Any
then
other any other differentials?
so it could be infective causes as well.
Yeah.
So um like but then the patient doesn't have any travel history, so considering malaria sort of a thing, that wouldn't be, I mean, a possibility because the patient doesn't have any travel history as such.
What'd you make of the hepatomegaly?
Yeah, so hepatomegaly, yeah. So hepatomegaly, I mean, there's no previous viral infections or anything like that, and the patient is not jaundice, but yes, definitely there is hepatomegaly as well.
Okay. End of station.
Right.
Um. Right.
I never
No.
got,
Hmm?
I never got anywhere.
Um. What was your list of differentials before you went into the station?
So yeah, it was around infections and then endocrine disorders. So that's what I was thinking about. Endocrine and infection predominantly.
Yeah. I think this is the slight danger with, because of the going down just a pure tremor route. Um. So I would suggest that maybe um think about a more wider differential list.
Right.
I'm going to give you a longer list here. Oh, hold on.
Right.
Um,
Okay.
so the actual answer in this case was alcohol withdrawal tremor,
Right.
but and this was a real station. So I think you didn't really pin down the alcohol history. I didn't think.
Yeah.
Yeah,
Yeah.
essential tremor is quite common, as you can imagine. So, did you ask about caffeine, stress, and things like that? Just remember how short the history was, right? The history was like a day or two.
Yeah.
Yeah. So I think the question of when was the last time you drank would be quite key here.
Right.
So thyroid I think you dealt that. Did you ask for a cerebellar exam?
No.
So that would have helped you with both alcohol and well, the cerebellar tremor.
Yeah.
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 Huntington's and Wilson's are in a
Right.
clinical consultation, you'll pick up a bit easier. But Wilson's could be a differential for hepatomegaly as well as the tremor.
Right. Right.
Have you got any questions on that?
No, that's fine. Thank you.
Anyone else got
Can I
any other
just
questions on that?
quickly? I think that's quite, I don't know, when you kind of write it down in black and white, like when you see people like that in A&E, you just take one look at them and you're like, that's alcohol.
Yeah. No.
Smell it, and that's alcohol. It's quite, it's like to put a sort of story across of it in a PACES exam when you're like talking to somebody who's quite well, trying to tease it out.
Yeah.
It's really tricky. I don't know. My gut feeling on this is that there are stereotypes can be useful in this exam. Like young people, inevitably there's a drug or an alcohol or or an opportunistic infection, like sexual history, travel history problem.
Yeah.
I don't know if that was giving you some teasers on that.
So you're absolutely right. So actually they used an actor for this. So I asked specifically what because obviously you can't just bring someone who's actually actively alcohol withdrawal, right? It would be probably a bit too hard a station. So they brought an actor because one of the things you have to remember is that PACES obviously is real life, isn't it? So you've got you've got patients who drop out last minute because they become ill and they just have a few backup sort of stations like this. Um, I think the take-home message I would argue or I would suggest is that differential list of it's quite key because you can only think of something because of that list. So the person who did the station was like, obviously they were a bit shaky and they actually had an essential tremor. But sort of, but the slight was alcohol withdrawal. If you mentioned essential tremor, obviously it'll be fine. But, I mean, he mentioned essential tremor and he was fine with it, but he had to ask about the alcohol and really delve down into it. But I take your point that in A&E, when you've seen someone who's drunk a lot of alcohol, it's a lot easier.
Hi, Dr. Vishnu.
Yeah.
How would you explain the rise of the WBC count in this alcohol, if it's a tremor related to alcohol? Will that go high?
Yeah. So I guess that's sort of reactive, an acute phase sort of reaction. I put it in there to throw people off. Not yeah, and it clearly worked.
Oh, okay.
Yeah. But you've all seen this, haven't you, where if someone's got a high white cell count and sort of like it's not an infection, it's just reactive sort of response to something. So that's what I was going for here. The hepatomegaly was just to try and help you guide into it, and in actual fact he had completely normal abdo exam as well, but he had an abnormal cerebellar exam.
All right. Thank you so much.
Any other questions at all? Any other questions? Okay, so we do the next station then. I've got Peter on my list.
Hi, it's me. Thank you.
All right, Peter. So here's your station, the last station. So have a read of that and let me know when you're ready.
Oh.
You ready?
It was disconnected just temporarily. I'm just gonna try again. I can't really see the prompt for some reason. Oh yes, I can see it now.
Okay. Okay.
Yes. Yeah. Sorry. So yeah, I'm ready. Thank you.
Okay. Sorry, I'm just making sure that everyone else on the call can unmute it and talk if they need to after your station. All right. Same as usual. I've started the timer.
Hello. Hi. My name is Peter, one of the doctors here. Thanks for coming today. So, I understand you've been feeling a bit unwell. Can you tell me a bit more what's been happening?
Yeah. So um I've just been feeling really unwell for the last sort of couple of weeks, to be honest. Been pretty tired and been vomiting at home.
I see. Okay. Could you just maybe take me back to the beginning, a couple of weeks ago? How did those start? And is there anything else that you noticed a few weeks ago?
Well, I think it just started just me noticing that I was a bit more tired than usual. And then
Mhm.
For the last sort of week, I've started, I've just been nauseous, and I've just been started vomiting. I've not been able to keep everything down. Am I mean, like I'm dark skinned, I'm a black, but like I've seen some pigmentation, like change in my skin.
Okay. So by pigmentation, you mean like if you can show me, you're like lighter than usual or darker than usual?
Both, I think.
Both darker and lighter than usual. Okay.
Like in different places, like my skin has changed color.
Okay. I see. I see. Okay.
But that's, I mean that. So I've always had slightly strange skin. So I think I have this thing called it's like vitiligo or something,
Oh, I see. Okay.
right? So I've always had. So I didn't think much of it.
Okay.
Um,
Okay.
yeah.
Okay. I see. And assuming you have some nausea and vomiting as well. Have you vomited blood at all?
No.
Okay.
The, yeah. I mean, I feel bloated as well all the time as well.
Mm, I see. I see. And importantly, have you lost any weight recently since all of this has started?
Yeah, definitely.
You've lost quite a lot. How much weight did you lose over the past few weeks?
Probably a few kilos. Yeah,
Mm,
probably about. I've not weighed myself, but definitely a few
mm,
kilos.
I see. Okay. Um, okay. And have you noticed you were passing urine more than usual?
Um, Probably no. I've not noticed that.
Mm, I see. Okay. And do you have any pain in your tummy at all?
No, I don't.
You don't have any pain. Okay. Um, and okay. Have you ever collapsed because you were feeling dizzy?
No, I haven't.
No. Okay. Have you got a headache at all?
Um, Maybe lightheadedness.
Sorry, maybe.
Lightheadedness.
Okay. Lightheadedness. I see. And I guess you can't. And you have been vomiting, but roughly how many times do you vomit?
Well, it's sort of stopped because I've not been eating anything, I guess, for the last couple of days.
Mm,
But
mm,
maybe sort of three times a day in the start of the week.
I see. I see. And is your bowel sort of? I understand when you stop eating, you don't really pass any motions. But like before, while still eating, did you have any sort of loose stools or bloody stools at all?
No, I didn't have any loose stools or bloody stools. No.
Okay. Okay.
I mean, I've had loose stools in the past, but not recent. I don't think.
Okay. Not recently. Okay. Good. And then what about your waterworks? Is that working fine?
Yeah, it is.
Okay. And um, okay, just wanted to have you noticed any joints aches and pains at all?
I guess that I guess my entire body just feels sort of weak. Not
Mm,
pain, just weak.
just pain, just weak. Um, have you noticed a fever associated with this the whole time at all?
No,
Okay.
no,
Any sweating at night, drenched in sweat?
no.
Okay. And okay. Right. I'm just going to ask a bit more about another might be a private question. Is there any possibility you could be pregnant at the moment?
I don't think so.
Okay. And you're confident that, I'm sorry, I'm probing a bit more, but the reason you're quite confident is because,
I just don't think I would be.
okay. Okay. All right. And when is your last period?
Probably 3 weeks ago, 2 weeks
3 weeks ago.
ago.
2 weeks ago.
Yeah.
Okay. 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 Sounds good. And I just want to ask a bit more about your past medical history now. So I know you have asthma, and any other you have vitiligo that you mentioned. Any other problems that you have?
Not that I know of. I'm allergic to nuts and stuff. That's
I
it.
see. Okay. Are you on any medication at all?
Inhalers for the asthma.
Okay.
and not it's not usual, but I sometimes need steroids.
Mm, okay. So would you say your asthma is reasonably well controlled in general?
Yeah, it is now. I'm on a new
Okay.
inhaler.
Okay. Okay. So you're just taking the inhaler, the two inhalers. Okay. No other
Ooh,
medication?
no,
Okay. And are you on any contraceptive pills?
no,
No. Okay. You mentioned allergies to nuts. Any drug allergies?
none that I know of.
Yeah. Do you have any family history of any diabetes or any hormonal or gland problem at all that runs in the family?
My my grandmother has thyroid, um,
Mm.
and my
Hmm.
grandfather has diabetes.
Hmm.
That's all I know.
Mm.
Oh, and there's asthma in my family as well.
I see. It seems like quite a lot of your family member has the immune-related problems and hormonal problems. Yeah. Okay. And have you traveled anywhere recently at all?
No. Do you think this could be due to hormones?
So could be due to
Hormones.
hormones. Uh, I think this is actually on my mind at the moment. I do need to do some more blood tests and examine you to confirm this. So, and you're definitely in the right place. And is there any particular thing that you're quite worried about?
Um, no, I mean you just mentioned it, so that's why I asked.
Right. Okay. Okay. And all these symptoms, how are these symptoms affecting your daily
You're
living? Yeah.
you're at 7 minutes past.
Sure.
But yeah,
Sure. Okay. I'm
uh,
gonna go on to examine, and then we'll examine the thyroid glands. I'll examine the abdomen. I will listen to check the heart, check the pulse, and I'll look at the eyes, do a thyroid exam, basically follow the thyroid exam. Um, and
sorry, that's a lot bigger than I expected.
mm,
So thyroid exam is unremarkable. Heart
mm,
sounds are are normal. What else do you want to
mm.
examine, sorry? Abdomen, you
Um,
said.
yeah, abdomen. Yeah.
That's also unremarkable.
Okay.
These are the only positive findings on your clinical exam,
Okay.
and other patches of vitiligo.
Okay. Okay. So, and okay. Thanks for letting me examine you. So I believe this, based on my examination and your history, I'm quite worried about this might be something that's related to the hormones. And I think the only way to confirm this is to do some more investigations, including a blood test. And because if it's a hormonal issue, I'll be rather concerned. So I think that you do need to stay with us uh, in the hospital for at least a few days to make sure that you're safe. So it's really good that you came to us, and then we can sort this out and get to the bottom of it, because it's definitely impacting your life. How does this sound? Do you have any questions?
Yeah. Which hormone?
So it's hard to say now, but I am particularly concerned about the hormone. Uh, well, I'm suspecting you might be lacking a hormone. We call it the stress hormone. And this is particularly, it's because of you have a bit of patchy, the increased pigmentation that I'm a bit concerned that might be the case. But however, we still need to sort of do more investigations to confirm this.
Okay. So you're going to do more tests.
Yes, yes, we'll have to do some more blood tests. And then in the meantime, we do need to, uh, we might have to give you some fluids to the drip, to the veins as well. And if it is this particular diagnosis, you will receive medication through some drips to temporarily
Will I
supplement. Yeah.
will I ever be cured from this?
So it's really early to make any conjectures now because we don't yet have any results. But so I think it's better that we have the results first, and then we'll have a chat later today, and then we can tell you a little bit more about that. How does that sound?
Yeah. Okay.
Okay.
So let's start with Viva. I'm only going to ask you a few questions. So what's the
So
diagnosis, do you think?
um, I think my top differential would be Addison's disease. Addisonian crisis, given the patient is very tachycardic and has low blood pressure with hyperpigmentation, likely secondary to excessive ACTH production. And however, I would also like to check the differential, given the fact that the patient has nausea and vomiting and weight loss. I would suspect is the first presentation of DKA. So I would like to definitely check the blood sugar, urine ketones, and HbA1c and C-peptide to confirm the diet and any other anti-GAD antibodies. And the pregnancy test, even though the patient did mention I still wanted to just do a pregnancy test in a young female without ectopic pregnancy.
Okay. What's the long-term treatment for someone with adrenal insufficiency?
So it will be depending on the etiology. The most common cause is autoimmune, which I believe is highly likely in this case because the patient has already a lot of risk factors and family history. So if that is the case, then unfortunately the patient will require supplementation of steroid therapy, whether it's in the form of hydrocortisone or fludrocortisone, depending on the extent of the adrenal glands being affected.
What other tests can you send for adrenal insufficiency? Because you've sent quite a few for diabetes, I think.
Yes, so to confirm the diagnosis of Addison's disease, we need to first do a random cortisol, actually ideally a morning 9 o'clock cortisol to check the levels, whether it's high or low. If it's concerning, then we will do a synactin test, short synactin test, which will really involve injecting synactin, and then we're taking serial blood tests to check for cortisol rise. If there's an insufficient rise, this can be used as evidence to diagnose Addison's disease.
Okay. End of station.
Thank you very much.
Any sort of thoughts, immediate feedback from anyone else? And then any questions? How do you think that went, first of all, Peter?
I think it's tough because there were several things I wanted to sort of clarify, and they're all kind of like quite similar. You have the ectopic pregnancy, you have the diabetes, DKA, you have the Addison's. So I was kind of like, I wasn't completely sure if that hyperpigmentation points towards Addison's. So, but I think that's the only clue I got. So I took a leap of faith and just went with it. I wasn't completely sure.
What else could it have been?
So another pigmentation in the mouth, I was just doing some reading. It could be Hers-Jager's disease. That's give you pigmentation, but it wouldn't present like insecurity with bowel cancer and bowel polyps. So it's probably unrelated. I don't know.
Yeah. So basically, the sort of buccal pigmentation in someone of that ethnicity is actually quite specific. It's a good. It pushes you down the Addison's route. To be fair, I would say, but I quite liked how you did your history, because you kept a very open mind and went through everything.
Okay.
So and also, like, you don't have to actually examine. You just watch. You just look at someone and you can see they're pigmented. Do you know what I mean? Obviously, because we're doing online, we had to sort of manufacture the exam bit. Yeah. Whilst I've just said this is the emergent treatment. So just remember to know your doses and things like that. Any questions on how you anything from the station from anyone? I think everyone can talk.
I guess if that was in the setting of a pan-hypopituitarism in terms of secondary causes of low cortisol levels, would it be appropriate in this scenario to ask for other hormone depletion like estrogens or things like libido or menstruation and other features of that, basically? Thank you.
Yeah, absolutely. I mean, basically, you would take a pituitary history. The reason why this is not pituitary cause of adrenal insufficiency, so not secondary, is because of the pigmentation, and also the significant autoimmune features. So you've got asthma, vitiligo. But there was actually a suggestion of celiac disease. I'm not sure if you got that, Peter. I was trying to indicate bloating. not acutely, but like in the past. And also the family history was it was meant to be type 2 diabetes, but also thyroid, which tends to be autoimmune or tends to be point to an autoimmune thing. To come back to your question, yes, you would screen for every single hormone. So you FSH, LH, so that's um menstruation in females, in women, and in males you talk about libido, erections, early morning erections, and things like that. Other hormones, prolactin, you ask directly about lactation and headaches. Prolactinomas tend to be quite significant, so they get large before they cause symptoms, all the symptoms. That's why you get the visual field effect. So you test that, because if you pan hyperpitch, you can also get high prolactin because there's no inhibition. Next thing is TSH. So you you go for the thyroid stuff, and ACTH, which you've done exactly what Peter's done here. Growth hormones are actually quite harder to test or ask questions about, but you can ask about mood, and if they're a bit younger, you can ask about velocity and things like that, growth velocity and things like that. But in a 24-year-old or 30-year-old, it's a bit more tricky to ask about growth hormone sort of deficiency symptoms, if that's helpful. Any other questions at all?
I wanted to ask, was the history of asthma and previous steroid use of significance in this case? Would it be a steroid withdrawal at the
Yeah,
same?
so I actually dangled it a bit. So I came up with this case to sort of, we could have gone down that route. So if you asked me a bit more of the steroids, I would have said, yeah, I've used so I actually wanted it just to be pure like primary adrenal sufficiency, because that's how the case was set up. But you could argue that, could it be like iatrogenic, or like a exogenous steroid use? What would go against that in this history / exam?
With the vitiligo, or rather the pigmentation changes, maybe, Vishnu?
Yeah, absolutely. The pigmentation puts you away. Just remember, the pigmentation is because you're just going back to physiology. Your POMC breaks down to your ACTH and your MSH, and your MSH is the thing that gives you the pigmentation. So you wouldn't expect exogenous steroid use would suppress your own endogenous ACTH. So therefore, you wouldn't expect the pigmentation. So that'd be the thing that pushes you against it. Yeah. Uh,
Sorry. Thanks very much for the talk. I just wanted to ask you, in practice, would you see many cases of people with sort of adrenal suppression with sort of repeated steroid use, say for asthma or COPD? Or would it take a very
um,
long dose of steroids to cause that?
So usually it's the latter. So usually it'd be people that have been on like 30 milligrams of of steroids. So like a short course of steroids does not cause adrenal suppression. It takes a while to suppress your adrenals. But it's actually the people that are, they wean themselves down and they get to like 5 milligrams and just end up staying on it. So those are the people that get an adrenal crisis of, like, so 5 milligrams of prednisolone, for example, is actually super physiological. Most people would probably only need somewhere between 3 and 4 milligrams. Okay. So yeah, those are the people. Is it theoretically possible, which is what your question was? I guess it's theoretically possible if someone took like I don't know, 10-day course maybe, or if they kept on getting repeated course after course, then like yes, you do start getting your adrenals do start coming, shutting down. So if you, I don't know, needed a rescue dose, a course of steroids every, I don't know, 2 weeks or something, well then you probably are going to start suppressing your adrenals. And we've got a few people in the endocrine department who are sort of that story and have managed to suppress their adrenals by repeated courses of steroids.
Thanks very much.
Any other questions at all? I'm just gonna just do a quick summary slide, and I'll invite more questions if that's okay. And I will also just before I do that, here's just a link, as I promised earlier, otherwise I'll forget to do this, for our next diet. So yes, just to emphasize, that's the second diet. So I think the clinical consultation is quite a challenging station, but I think preparation is key. So even the sort of time that you have beforehand, you go into the station. I think that's really important. Last thing I will say is just practice. And think about what the examiner wants you to do. They want you to be a medical registrar. Okay, so they're not interested in you knowing the last diagnosis of the fifth diagnosis, for example. They don't want you to know every single cause of it. They want you to be a safe medical registrar. Don't have to do full examination, so please don't do a full top-to-toe neurological examination unless it's indicated. Unless the case is, I don't know, motor neuron disease or Parkinson's, then maybe that's indicated. But choose your exams carefully. So if you're examining someone for a stroke, I wouldn't expect you to do all modalities of sensation. Okay, I would expect you to do mainly tone, power, reflexes because they're the most sensitive signs. And I will stop there. Any questions at all?
No.
Okay, well, so no questions. I'll going to end the webinar here. Do you have a list of cases for clinical consultation? It's been populated on the website, I think, eventually, and obviously we're getting through the webinars. There isn't an exhaustive list, to be honest. Sadly, there's not a they also generally like make new lists, new cases every single year, because of the nature of the exam. So yes, in short, there isn't an exhaustive list that I have to hand. I sort of come up with the cases based on previous cases that I've heard and also my own sort of judgment.
Thank you.
Any other questions? All right, well, we're all on the WhatsApp group, so you can always ask questions on there. I'm going to stop the recording.